Dear participants, I'd like to welcome you all to the International Society of Geriatric Oncology and Turkish Geriatric Hematology Association joint workshop. And first of all, I'd like to thank Raul Cordoba, who is the president of the European Hematology Association Scientific Working Group on Hematology and Aging. Also, Dr. Cordoba has made great contributions for the Turkish Geriatric Hematology Association to take place in the SIOG and to hold this meeting. The proportion of the population over the age of 65 in Turkey this year is 9.5, which is lower than the population in European countries. However, more than 8 million people are over the age of 65. In a projection we have carried out, it is expected that more than 20,000 new diagnosis hematologic malignancies will be observed in 2021. As an association, we have working in recent years to give elderly patients the treatment they deserve. We are trying to spread the principles of personalized medicine to the entire hematology community. For example, if the patient is fit regardless of his age, the health authority and reimbursement institution pay the treatment cost for hematopoietic stem cell transplantation. On the other hand, silver tsunami is an important fact both for the world and Turkey. Also, this study entitled Implementation of Geriatric Hematology Programs for the Treatment of Adults with Hematologic Malignancies in Reserve Limited Setting will publish in the Lancet Healthy Longevity Journal under the leadership of Dr. Raul Cordoba. I would like to thank the Executive Administrator of SIOG, Lawrence Jokeil, for organizing this workshop. I would like to thank all the members of the Board of Directors and General Secretary Zafer Gülbaş, all of whom I am honored to be here again. Now, I would like to invite the workshop co-chair, Dr. Raul Cordoba, to give his speech. Dr. Cordoba.
Thank you very much for the invitation, for being in your symposium on geriatric hematology. I am here on behalf of the International Society of Geriatric Oncology, SIOG. Now I am a member of the executive board of this society, and for us it's a pleasure to organize a joint symposium with you. As a reminder, the International Society of Geriatric Oncology is a multidisciplinary membership-based society with members engaged more than 80 countries around the world. This network includes not only geriatricians, but also oncologists, hematologists, radiation oncologists, nurses, and all allied health professionals. This international society has been founded in the year of 2000, and since then we have been working in order to implement activities in the field of geriatric hematology. And recently, I cannot remember if 2 or 3 years ago, we have national representative of SIOG in Turkey. So you were very welcome to be part of this international society. So for us, it's a pleasure to organize this joint symposium. And as Professor Ilham already said, we have started working together in order to help other centers to implement a geriatric oncology and geriatric hematology program. And as already shown, we are going to publish our first collaborative work. It's going to be released in October the 5th. So it will be able to all the geriatric hematology community in that day. So I finally want to thank again for the invitation. Very welcome to all of the attendees, and hope we can learn with all the invited speakers, not only from Turkey, but also from other parts of the world, in order to learn more about geriatric hematology. Thank you very much.
Thank you, Korboba. I want to announce the first speaker, Dr. Toby Eyre from United Kingdom. Topic is current treatment in geriatric lymphoma patients.
Many thanks for the invitation to speak at the Turkish Geriatric Hematology Association joint workshop. And thank you to the International Society of Geriatric Hematology for sponsoring this workshop and for the invitation from Dr. Cordoba. My name is Dr. Toby Eyre. I'm a consultant hematologist at Oxford University Hospital's NHS Trust in the UK. And it's my pleasure to talk on the management of elderly patients with diffuse large B-cell lymphoma. These are some of my disclosures. Okay, so there's a lot to cover, and this is a big topic, and there's a lot of recent data to get through. So I'm going to give a brief overview on the following areas, and I hope this is of interest and of value. So I'm going to talk briefly about geriatric assessment. I'm going to focus quite a lot on R-CHOP-based therapy, and looking particularly at dose intensity decision-making, because this is a kind of key topic within the management of elderly patients with DLBCL. And then I'll talk a bit about CNS prophylaxis, which is always been a contentious area, and in the elderly, that's certainly also the case. I'll talk about non-anthracycline-based treatment options, some investigational approaches that have been studied recently in elderly DLBCL, and then importantly, cover some aspects of supportive care, some of which you can see listed there: pre-phase therapy, infection risk, bone health, and long-term consequences of anthracycline-based therapy. So lots to cover. I hope this will be of interest, and here we go. So diffuse large B-cell lymphoma in the elderly is increasingly common. The incidence is rising, and over the next 50 years, we expect those patients over the age of 85 to increase by fourfold. Now, of course, the survival with DLBCL is inferior in older patients, and this will be due to multiple reasons, as I'll show you with some of the data I'm going to present. Comorbidities, decreased physiological reserve and functional capacity to withstand immunochemotherapy and enable adequate dosing strategies. Dose-intense therapies are clearly not feasible in the elderly, and there's certainly some evidence that biologically the disease is more challenging in certainly subgroups of elderly patients. One of the issues kind of up until at least recently is there've been a real dearth of clinical trials in elderly patients per se. And if you look historically at most of the randomized data over the last 20 years, very, very few patients over the age of 80 have been in those studies. And so if you look into consensus documents and so forth, like this one I've listed here, you can see here that really they list these challenges and talk about how we need to optimally categorize elderly patients who are fit enough to receive curative therapies and ensure that there's some kind of consistency in our decision-making approaches. I'm going to talk briefly about geriatric assessment, mostly actually about the challenges that they face. So this is really just a kind of summary slide, just really to demonstrate that there are multiple different comorbidity indices that are available to use. Some of them simplified, some of them more complex, some of them involving functionality for individual patients, others involving a range of both clinical, biochemical, and also physical parameters. And I've just really listed those there. I'm not going to go into huge amounts of detail about each one. Just to say there's a recent review that myself and Dr. Cordoba and Stefano Luminare wrote, which is available in the British Journal of Hematology, which does cover some of this in more detail. I am going to talk about one of the key geriatric assessment tools that's been published recently, mostly because it's one that's been performed in a large number of patients and also been validated in external validation set, so it has certainly a robust nature to it. So this is a prospective elderly project from the Italian group, looking at over 1,000 older patients with DLBCL. What they did here is they categorized patients according to the simplified geriatric assessment tool. And you can see that listed there in table 1 at the top of your screen. So patients were divided according to their activities of daily living, their SIRS-G score, so a kind of cumulative comorbidity score, and also by their age. And patients were deemed to be fit, unfit, or frail on the basis of this. And you can see that 55% of patients fitted in the fit category, 28% in unfit, and 18% in frail. And as you can see here by this Kaplan-Meier curve, this clearly demonstrated a really nice differential in terms of overall survival. Now they built on this, and they used these groups to then add in additional factors and plug in these groups into a kind of larger multivariate analysis, as I'll show you on this next slide. So the different groups are included in a Cox regression multivariate analysis, along with other clinical factors and biochemical factors. And what was found was that those who were unfit and frail were independent risk factors, and indeed those with a high IPI and a low hemoglobin. And so a subsequent scoring system was devised called the Elderly Prognostic Index. And this took factors, the following factors and provided a scoring system of low risk, intermediate risk, or high risk based on the score, the kind of weighted index that you can see here, and the scoring system related to that. This was performed in their initial training cohort, and you can see here it's very discriminatory in terms of overall survival, but also in a subsequent validation set, and you can see here it performs well in that set. So using a simplified geriatric score, IPI, and hemoglobin, you can begin to pull out which patients have both superior and inferior survival. So it's all very well, and in many respects there's observational and of course of interest, but what do we do with that information? I think that's one of the really challenging things with a lot of these scoring systems, in that we really struggle to know how to actually use the information to make decisions. And it is certainly my view that randomized trials need to be performed in these different groups of patients to get an understanding of what best therapy is used here. So I give this slide as simply an example. It's not something that necessarily is the right thing to do. I'm just giving it as an example of the kind of thinking that we may need to consider. So, for example, perhaps in the more frail patients where you don't know whether to use full dose or R-mini-CHOP dosing, those with a higher risk, so an elderly prognostic score 6 to 8, you could consider randomizing between full dose R-CHOP and R-mini-CHOP, or indeed using the intermediate group if you think that that's more appropriate. But something along these lines may enable us to provide prospective evidence for prospective decision-making around therapeutic strategies. And it'll be interesting to see whether I suppose the geriatric oncology community kind of embrace this kind of idea moving forward, so that we use these scoring systems to provide a really high-level prospective evidence. Okay, that's a brief bit on geriatric scores. What about dose intensity? Now, this has become really relevant in the last 10 years or so, really following 2 clinical trials performed by the LISA group, who have been extremely active in the field of elderly diffuse large B-cell lymphoma. The first of these studies, now published 10 years ago, really establishing the use of R-mini-CHOP in patients over 80. So this is a phase 2 non-randomized study of 150 patients, all of whom were over 80. Cyclophosphamide, doxorubicin, and vincristine were all given at reduced dose, so 400 milligrams per meter squared, cyclophosphamide 25 milligrams per meter squared, doxorubicin 1 milligram of vincristine. And you can see here that this enabled patients to be cured actually from their high-grade lymphoma. Certainly on the progression-free survival curve, there is a plateau, and patients develop durable remissions following this therapy in approximately 50% or so of patient cases. And so this was really the first time that that the wider community really adopted anthracycline-based therapy in elderly patients. A subsequent study was performed using ofatumumab, so a different CD20 antibody, again with the same doses of CHOP chemotherapy, and similar results were found. Debatably slightly better, although clearly this combination hasn't really been adopted more broadly. There were no toxic deaths in this study, unlike the mini-CHOP study, and I'll talk a little bit more about that when we discuss pre-phase therapy. One interesting factor, and this I think is really relevant, is if you look in the mini-CHOP study initially, the only independent risk factor for overall survival was serum albumin. This has been shown on a number of occasions to be really quite strongly prognostic in elderly DLBCL. Okay, well, so we've got some prospective data in younger patients using full dose R-CHOP and some prospective data in very elderly patients using R-mini-CHOP. Well, you know, how do we kind of make sense of that, and how do we marry up the challenges that both dose intensity, decision making, comorbidity, and age play out, and how do they interact? Well, there's some registry data and some large retrospective series which help inform decision-making here. This is a Danish registry of 1,000 patients, and patients were either initiated on what was defined as standard treatment, so curative R-CHOP-based treatment in 64%, and this was a higher percentage in younger patients, so those 70 to 75, 83% received so-called standard therapy, whereas, you know, those who were over 85 much less did, perhaps unsurprisingly. And with standard therapy, survival worsened over the age categories that you can see there. So again, unsurprisingly, those who were between 75 and 79 did better than the older two age group categories. What is interesting is if you look at the patients over 85, and I'll come to this a bit later, but actually overall survival wasn't influenced by treatment intensity, and that will be for multiple reasons, not least for competing risks of mortality in that group of patients. And if you look at those over 80, there were fairly similar. Those between 80 and 84, as you can see here in the Kaplan-Meier curve, reduced dose intensity of greater than or less than 80%, and that was defined by cyclophosphamide or doxorubicin dose reductions, had actually no bearing on people's overall survival. So certainly suggests that R-mini-CHOP is appropriate in that group, and I'll talk more about that in a minute. There's a separate Swedish registry study, which is again provides interesting data, and I'll just show you this analysis here. These are hazard ratios for mortality, and what you can see here is the specific causes of death along the top, and then down the side the Charleston Comorbidity Index. Just to take the first column, you can see that perhaps unsurprisingly, all causes of death, the hazard ratio increases as comorbidities increase, and no surprise there. That's true for all causes, as mentioned, in those treated with curative intent. But of course, the hazard ratio is slightly lower because these are generally fitter patients. But what is interesting is that in those treated with curative intent, with increasing comorbidities, you can see here that the lymphoma-specific deaths don't increase, whereas those patients dying from other causes do. So I suppose this suggests two things. Clearly, those who have higher the higher comorbidities do far worse, but this is primarily driven actually not by their lymphoma per se, if they can receive curative therapy. So I suppose it at least encourages us to consider using a curative-based approach in older patients where we can. Okay, that's really an introduction to dose intensity. This is a series that I led in the UK, published now a couple of years ago, looking at just under 700 patients over the age of 70 and assessing the role of both what is described as intended dose intensity, so the first dose of the first average dose of cyclophosphamide and doxorubicin within the R-CHOP cycles, and compared the influence of that with both survival and also the importance of relative dose intensity, which is the collective sum of the dose intensities across the cycles of R-CHOP divided by the number of dose delays and so forth, or at least corrected for that. I'll just walk you through this just quite quickly. These are the number of patients given each cycle, and you can see the majority, but not all patients, had 6 cycles of R-CHOP. Or R-mini-CHOP or a dose in between. You can see this is across all consecutive patients over 10 years across 8 hospitals. So you can see obviously there are some patients that got far fewer, but most patients got 6 cycles of R-CHOP. Intended dose intensity according to age. So what you can see here is that those who are under 70, so between 70 and 80, the starting dose is most commonly full dose R-CHOP, whereas in the over 80s, the reverse is true. The starting doses are typically R-mini-CHOP. If you look at panel C, what you can see here is that this is looking at a ratio of relative to intended dose intensity. So what this does is it basically allows you to see whether patients who got either full or mini-CHOP or a dose somewhere in between followed that pathway throughout their therapy. And of course, those that had a ratio that was greater than 1 increased their dose, and those that had a ratio of less than 1 decreased their dosing over the course of time. And what you can see here is that actually most patients follow the initial dose that they started in. So you can see here that basically most patients, the vast majority really, sit with a ratio around 1, both in the younger group and indeed in the older group. This, of course, predominantly being around the ratio around our mini-CHOP dosing. And this schematic really demonstrates that in more detail. So you can see the ratio up the side here, the dose intensity down here, and the age cutoffs here. So just to walk you through it, in the younger patients, most of them get 100% dosing. And of course, very few increase the dose. So you're not going to see people with a ratio that goes up in this direction. And a few patients dose reduce. And similarly with the R-mini-CHOP, some people dose reduce, so go this way, but actually some people do increase the dose here in the younger group. So there is a percentage of people who start off with R-mini-CHOP dosing and have an increased dose. And in the elderly, in the over 80s, what you can see here is the mini-CHOP is the starting dose. And there are occasional patients that go up, but slightly more that go down in dosing, and a small percentage there. But you can see this intriguing group in the middle where there are those over the age of 80 who get somewhere between mini-CHOP and full dose, and actually a few go up and a few go down. And I don't think we really know kind of what to make of that group, and it hasn't been particularly well studied in the past. So what about the results? What about the results here? So first thing to say is that this is the progression-free survival of the whole cohort. So again, showing that there are durable responses in quite a few patients and probably curative potential in about 50% of patients. What is important is that, and to recognize in elderly people, and I've already kind of really described this to some degree, is that some patients will progress over time, but also other people will die without progression. So there are competing risks for mortality whenever anybody's analysing elderly DLBCL. What you can see here is across the cohort, the whole cohort, perhaps unsurprisingly, younger patients have a better progression-free and overall survival than older patients. But actually, if you look at their cumulative incidence of progression, there was no difference between the two groups. Now, this is one of the key slides really, because this really kind of at least helps us work out what we should do with different groups of patients. And what this slide shows is that those who get reduced dose in the under 80s do significantly worse. So this is the blue curve here for progression-free survival, and here for those under 80. Now, of course, if you think about why you might dose reduce in those under 80, of course, there'll be lots of comorbidities, lots of particular reasons why you might do that, frailty, amongst other things. And remember, this is intended dose intensity. So this is the first dose we're talking about here, divided by less than or greater than 80%. So the reason why we use intended dose intensity here is we didn't want relative dose. Relative dose intensity is so clearly caught up with your clinical course that actually it'd be very difficult to really use that to any great degree, because, for example, if you got a pneumonia after cycle 2, you're highly likely to dose reduce and have a worse outcome as a result of that event potentially. So that's why intended dose intensity was used here in this analysis. But what you can see is that those over the age of 80, actually their overall survival, progression-free survival, wasn't influenced by whether they had an intended dose intensity of greater than or less than 80%. So really certainly suggesting that in the over 80s, it's very reasonable to dose attenuate and give effectively what is our mini CHOP rather than full dose CHOP. This has been looked at in a systematic review that's been published really very recently, only about 3 weeks ago, in Blood Advances. I collaborated with colleagues from actually around the world to do this piece of work, and we looked at all studies who analysed dose intensity of R-CHOP-based therapy on survival outcomes, actually since the initiation of rituximab-based therapy, so since 2002, right up until November of 2020. And we looked at a number of different factors, looked at the way dose intensity was calculated, and looked at the influence of dose intensity on survival. And broadly speaking, and I'd encourage people to have a look at this, this piece of work, it's open access. The majority of studies that were reported a crude analysis did show that lower dose intensity was associated with worse survival. And some studies used dose intensity as a covariate within a multivariate analysis, and 6 of these 10 studies showed an association with worse survival. And one of the take-home messages here is that in the studies that looked at patients over the age of 80, survival wasn't consistently associated with reduced dose intensity. So clearly a suggestion here that dose attenuation, i.e. mini CHOP in the over 80s, is very reasonable. Okay, those are the kind of key points I wanted to make about dose intensity. What about CNS prophylaxis? This is, again, a UK study that I led and again published a couple of years ago in the British Journal of Hematology. Actually, same patient cohort, so nearly 700 patients over the age of 70. CNS prophylaxis was given according to physician preference. Median age was 77 and median follow-up was 2.8 years. And really the take home here is that the CNS IPI predicted CNS relapse risk, but the risk really overall was low. So the risk at 3 years was 3%, 2 years 2.6%, so relatively low. We didn't really see any clear influence of intrathecal prophylaxis here, but what we did see is that actually it was independently associated with infection-related admission, interestingly, in those who received intrathecal prophylaxis. So some evidence certainly of harm and really minimal evidence of benefit in this series. The LISA group have pulled their 2 phase 2 trials and looked at the cohort of patients from the R-mini-CHOP and O-mini-CHOP studies. So this then equated to 270 patients overall. And no patients, interestingly, in this study received CNS prophylaxis. Median age was 83 in the study, so about 6 years older than the UK data. And this showed that no real characteristics were clearly associated with CNS relapse. and actually their rates again were very low. Their conclusion really was that for a variety of reasons, CNS relapse doesn't seem to be a really dominant problem in elderly DLBCL compared to, for example, death from other causes or systemic relapse. And so certainly on the basis of these two studies, any recommendation for CNS prophylaxis is generally fairly weak, and there isn't a lot of data that's studied, for example, high-dose methotrexate in older patients and looking at toxicity and so forth. And in the UK analysis, very few patients received high-dose methotrexate. So off the back of actually that study, and in parallel, we decided to look at the efficacy of intrathecal prophylaxis across the board, and really just look to see whether there was any clear association with a reduction in patients' risk of CNS progression across a number of studies. And so a group in Oxford, again led by myself, studied patients over just under 20 years and looked to see how many studies there were analyzing the effect of CNS prophylaxis. Now, I won't go into all of the details here, just to really say that the majority of patients had isolated CNS relapse, but not all. About a quarter of patients had concurrent CNS and systemic relapse. And actually, if you look at the proportion that had isolated leptomeningeal relapse, so the proportion that you might think might benefit from intrathecal therapy alone, actually that was just about a quarter of patients. The event rates were very low, and so it's actually very difficult to power an analysis to really detect a difference. But in no series was intrathecal prophylaxis associated with a univariable or multivariable as a multivariable factor associated with the reduction in risk of CNS prophylaxis. So we've certainly been very selective about the kind of patients we might consider intrathecals for in the very elderly. Okay, what about non-anthracycline-based systemic approaches to the management of DLBCL? So some recent data where etoposide has been used as a substitute for anthracycline. Now, clearly, not every elderly patient can receive either full or R-mini-CHOP for a variety of reasons related to cardiac comorbidities. And this is published in Blood Advances this year on the right-hand side. And you can see here that what the Vancouver group did is they did a case control matched analysis with 140 R-CHOP treated patients, so a kind of 2-to-1 case matched control with 70 R-COP patients, which they had in their data set. And what they broadly speaking showed is time to progression and disease-specific survival was relatively equivalent. And I think suggestion here of some long-term disease control, so certainly curative potential with this regime, and again, just under 50% of people. So that looks like a reasonable regime to at least consider for your patients. And this is not published data, but it's in press at the moment. This is some UK NHS England data from a few years ago of 166 patients with R-COP. And what you can see here is that the 3-year overall survival, again, is just over 50%, so fairly consistent, and looking like a potentially curative regime in a proportion of patients here as well. So a very reasonable option to consider for patients who can't receive anthracycline. The other regime that's quite commonly used is RGCVP, so R-CHOP-like treatment, just without the anthracycline, given on 21-day cycles, and the gemcitabine is used as a substitute and given on day 1 and day 8. This is a UK NCRI study led by Paul Fields from Guy's and St Thomas's. Median age of patients was 76 in the study. Just over 40% had a reduced ejection fraction less than 50%, and the other approximately half of patients had a reasonable ejection fraction but other cardiac comorbidities, either ischemic heart disease, problematic hypertension, etc. The response rate was 61% here, and again the 2-year progression-free survival, 2-year overall survival, just around about the same ballpark figure, so just about 50%. So Again, this regime looks like a reasonable option in a proportion of patients who have cardiac comorbidities. And this is the main prospective trials supporting this regime in this group of patients. What about RCVP? I mean, is it purely palliation, or is it more than that? Can it be used effectively in some patients? Here is the, again, UK NHS England data on the left-hand side, again in press, just to show that survival looks a little bit worse than the RCOP group. But you can see here that the 3-year overall survival is about 43%. So certainly a proportion of patients are doing really quite well here. And then on the right-hand side, I just want to kind of draw your attention to this is the Danish population-based data again. The RCVP was considered the less intense group. So this is rather than the standard group, this is the less intensive group of patients. And certainly in the younger patients, the less intense, so the kind of long dotted line here, the middle dotted line, clearly these patients do worse than those who receive kind of standard therapy. But I think what you can see, particularly as patients get older, you can see here that actually the overall survival really kind of comes together with the less intense and the standard group, certainly suggesting here that in those over 85, so those very, very elderly patients, RCVP may well actually be just as effective as using, for example, R-miniCHOP. And so certainly a reasonable consideration in that group of patients. Okay, what about investigational approaches? This is really this is a flagship study because this is the first ever randomized clinical trial using R-miniCHOP as the standard of care arm in those with frontline DLBCL over or equal to the age of 80. So this is a LISA-led study, 250 patients randomized to R-miniCHOP or R-miniCHOP plus lenalidomide. Now, I'm not going to go through all of the details in the interests of time, but just to say that many of these patients are very representative of the kind of patients we see in our clinic. A quarter of patients over the age of 85 enrolled in the prospective trial. So, you know, really hats off to the LISA group for enrolling these elderly patients into clinical studies. And you can see here that a proportion of patients had high-risk clinical features, including double expressor and double hits, etc. Unfortunately, though, the clinical trial didn't demonstrate, or the addition of lenalidomide here didn't demonstrate an improvement in progression-free or indeed overall survival, and there weren't even really any subgroups or indeed the ABC subgroup where you might expect lenalidomide to be more effective. None of those groups really found an improvement in survival in the investigational arm. I think what we do know, and what's perhaps unsurprising, is if you add in lenalidomide to R-miniCHOP, you do get more toxicity, not only just in cytopenias, but also in the risk of infection and thrombotic events, as is demonstrated here, but also GI toxicity as well as SAEs overall. So I don't think R-squared mini-CHOP is going to be taken forward in the over 80s, but a really good proof of principle that randomized clinical trials can be performed in this group of patients. And this is really just to show you that albumin came out as a strongly prognostic multivariate factor, so independent factor predicting overall survival here. So demonstrating that this is a really important prognostic factor in elderly DLBCL patients. The UK has recently performed and presented a study called the INCA study. So this is using inotuzumab ugamamycin, so an anti-CD20 ADC, where internalizes a calicheamycin toxin, which is a little bit like an anthracycline-based agent, and this is delivered via an antibody drug conjugate. This randomized study was performed using RGCVP as the control arm, and compared to RCVP plus inotuzumab. And this was really designed in a group of patients who weren't fit for anthracycline-based therapy. And you can see it as a one-to-one randomization performed there. You could use a steroid pre-phase beforehand, and PFS was the primary endpoint. Now, unfortunately, although the response rate was slightly higher in the inotuzumab arm, there was no difference in progression-free survival in this study, and no difference in disease-specific survival or non-relapse mortality. But what you can see here really strikingly is that the non-relapse mortality in this study was over 20%. So lots of patients in both arms, actually. So lots of patients, even in prospective clinical trial, lots of patients dying of unrelated causes or causes that weren't directly lymphoma related. So, clearly a lot more to understand here about how we deliver therapy in the elderly and how we best manage comorbidity and toxicity. Okay, and just to kind of finish off the last few minutes, I just want to talk a little bit about supportive care and give you some things to think about really in your clinic when you're managing elderly DLBCL. So first thing, and I've alluded to this already a couple of times, is pre-phase therapy. And I just wanted to use these two LISA phase 2 studies really just to demonstrate the value of pre-phase. So what you can see on the left-hand side here is the R-mini-CHOP group. I alluded to this earlier, but there was no pre-phase used in the study, and there were 12 toxic deaths in this study. Compare that to the O-mini-CHOP group, where a pre-phase of Vinc and prednisolone was used. And actually, interestingly, there were no toxic-related deaths here. So certainly demonstrating the potential value of using pre-phase therapy in patients with impaired performance status related to their underlying lymphoma. And this isn't the only evidence for this. There's some additional evidence from the German high-grade NHL group who have looked at this as well. Okay, so that's just a brief slide on pre-phase, and certainly I'd recommend using pre-phase therapy in anybody who has a reduced performance status before going in with full or R-mini-CHOP, primarily because the risk of toxic related deaths is generally within cycle 1 and 2. So it's generally fairly early on and tends to be related to infection, primarily respiratory infection. So I would consider that certainly in those patients. What about infections, and can we predict which patients will develop infective related morbidity or mortality? Now, this has been published just this year. Again, it's the UK group looking at this same patient population, looking at the risk of hospitalization and infection related deaths. So just the kind of top line here is that independently we found that the risk factors for hospitalization in those over the age of 70 were actually higher dose intensity. So interestingly, across the board, that was found to be an increased risk, and that primarily related to neutropenic fever rather than non-neutropenic fever. Interestingly, the patients who did not receive antibiotic prophylaxis were those who were at greater risk of hospitalization. And of course, there's quite a variable practice when it comes to antibiotic prophylaxis, but certainly this data suggests that it does reduce your risk of hospitalization on therapy. And then low albumin was the other independent factor. And again, I probably don't need to go over that again, but clearly another interesting feature there of risk factors for infection. What about the risk of death? Slightly different risk factors this time, but they do make sense. Those with a higher IPI are at higher risk of infection-related death. Those with a higher SIRS-G score are particularly at higher risk. Actually, they're in the weighted index, you can see there that I've put together. They actually score 2 points in that because they actually have a much higher independent odds ratio in the multivariate analysis in this study, and also low albumin there. So what you can actually begin to do is create a a cumulative risk of mortality score, which is what we've done here, dividing patients up by whether they had no points of those in that 4-point score for an infection-related death, 1 to 2 or 3 to 4. And actually, first thing to say is that if you score none of those points, so if you're not in any of those categories, you actually, out of 700 patients, there were no infection-related deaths. So clearly demonstrating that their risk is actually very, very low. Conversely, a score of 3 to 4, actually, if you look at this, the 2-year infection-related death risk is 15%. And the 5-year risk is over 20%. So really demonstrating that this group are potentially at very high risk of developing long-term infective complications. And actually, there's been some interesting data published in the JCO earlier this year, looking at people's longer-term immune function after treatment for high lymphoma, amongst other disease entities, and really showing that people do have really quite marked abnormalities in their immune system function for up to 5 years and longer following immunochemotherapy. What about patients' bone health? Again, this is something we have studied and looked at recently in a similar cohort, this time as 730 patients. And what we did is we analyzed patients. We included patients who had a minimum of 6 months follow-up from the start of R-CHOP. So we wanted to make sure that we excluded patients who died early of unrelated problems or progressed early or for whatever reason. But we also censored people at 18 months follow-up because we felt that kind of mechanistically it's probably more likely that any bone health related event was more likely to be related to the chemotherapy and the disease within that kind of time period. For right or wrong, it was an arbitrary cutoff. And we followed up these 730 patients to see how many patients had fractures during that 18-month period. And we actually, to our slight surprise, found that there were 81 fractures in that 18-month period. So really quite high, proportionally high numbers of patient fractures. And you can see here the cumulative incidence curve of the risk of fracture. And what you can see here is that at 6 months follow-up, the cumulative incidence was just over 6%, but at 18 months, it was over 11%. And again, we performed a multivariate analysis, looking at a range of potential risk factors, and found a number of factors which again led us to be able to produce a risk score here. So predisposing history, so osteoporosis, osteopenia, prior fracture or rheumatoid arthritis, they were included. If you had diffuse large B-cell lymphoma bone involvement at baseline, that was a factor, or indeed if you were a recipient of pre-phase steroids, interestingly. So, and again, you can see here the kind of division of risk according to the number of factors that you had. And if you had 2 or 3 factors, you can see here that your risk of developing a fracture within the first 18 months is actually really high. It's kind of 25% in those with 2 or more factors here. So whilst this isn't a randomized trial demonstrating that we can definitely prevent this risk, this certainly should lead us to think about how we can best attenuate patients' risk of fracture. This isn't the only series to demonstrate really these findings. There's a large Danish population series that was published in 2020 that showed lymphoma patients, follicular lymphoma or DLBCL patients actually had a higher risk of osteoporosis or low energy osteoporosis treatment or low energy fracture in the following 10 years post treatment. This was certainly most marked in female patients and in older patients, as you might expect. And so they demonstrate that really quite clearly on a population level. So we have produced our own local guidance, really using our risk score. So we kind of arbitrarily took a patient cutoff of 50 years, and we've basically suggested that in those without known osteoporosis, osteopenia, if they have any of the other factors that we mentioned, they should receive bisphosphonate and calcium and vitamin D. It'll be interesting to see what that does to the kind of cumulative incidence in the future. Of course, this could be studied in a randomized clinical trial really relatively easily, but of course, it would require kind of clear collaboration, but it would be possible to do. And just to finish, I just want to touch on anthracycline and toxicity. This is a important area and probably an understudied and under-recognized area in older patients with lymphoma. Now, this actually is a Mayo Study Clinic prospective study taking patients over the age of 18. And what they did is they captured all those who developed a cardiovascular disease event, so either ischemic heart disease, congestive cardiac failure, valvular disease, or arrhythmia, and looked to see whether there are any associations with those abnormalities over time compared to baseline, both clinical characteristics and also treatment. I looked at over 3,000 patients here and found that the cumulative incidence of cardiovascular disease at 10 years was just over 10%, and found on multivariate analysis that increased age, male gender, smoking, and indeed, and increased body mass index, but also any anthracycline use was associated with increased risk of cardiovascular disease. So really quite striking there. The main drivers of the anthracycline association were congestive cardiac failure. So if you had anthracyclines, you were 2.7 times more likely to develop congestive cardiac failure or arrhythmia, and the hazard ratio was 1.6. You weren't, perhaps unsurprisingly, at increased risk of acute coronary syndrome or valvular heart disease. And this slide really is just to show you on the right-hand side that this does seem to be dose-related, or at least cycle-related. So you can see here, this really is just dividing by the cardiovascular events down the left-hand side. So any cardiovascular event here and any of the four on down here. What you can see here is that the number of cycles of anthracycline does seem to associate with your risk, and that's true for those who had any of those risks, but particularly true, interestingly, for congestive cardiac failure, and potentially true here for arrhythmias as well. Really, I think this is just really something to kind of think about when you're using anthracyclines. Think about your dosing strategy. Think about whether you could consider using radiotherapy in appropriate patients who may be at much lower risk of long-term radiotherapy-related issues. But really, this is just to highlight that, we need to think carefully about using anthracyclines because they are clearly associated with long-term risk. And with that, I'd like to finish. We've covered a lot in a short period of time, and I hope it's been of interest and valuable. I'd just like to thank a number of both collaborators around the UK, Nottingham, Guy's and Tommy's, the Oxford Biomedical Research Centre, Statistical Help, and also the Julian Starmer Smith Lymphoma Fund, who supported some of this work, and of course patients and their families for contributing the data that I've presented. So thank you very much for inviting me to talk, and I hope the rest of the Congress goes well.
Thank you for presentation, Dr. Tobey. But Tobey is not online. Dr. Cordoba, what about the Spanish lymphoma group's new current therapy?
In Spain, we give our mini chop to our patients. Dr. Eyre has mentioned very well in his talk, we should not give a full dose of anthracycline beyond 80 years old. So if the patient is fit, we give R-CHOP until the age of 80, and beyond that age, we reduce the dose to R-mini-CHOP. And sometimes, if the patient has cardiac impairment, we use liposomal doxorubicin instead of the standard formulation. So we are also using this formulation of doxorubicin in order to get the best results in our patients.
Other than what about the SIOC, Society International Geriatric Oncology Group, for a proposal for my geriatric patient?
Yes, in the SIOC published in 2015, so almost 6 years ago, a publication about how to manage older adults with diffuse large B-cell lymphoma. And again, they say that over 80, we should use our mini-CHOP. And there are another options in those patients with cardiac impairments, like RCOP or using gemcitabine, as Dr. Eyre says. And another very important question is that if we want to improve the outcome, we have to improve the supportive care in these patients. So we must forget using the prephase with steroids, with or without cyclophosphamide, the use of GCSF, and give active infection prophylaxis. So if we give a very good supportive care, we are going to improve the outcome.
Thank you.
About the bendamustine in terms of to change the strategy.
The results published in first line using bendamustine plus rituximab are not very encouraging. The complete response rate is much lower than the response rate that we find with other strategies. Because we have to keep in mind that the dose of bendamustine that we have to give to patients with diffuse large B-cell lymphoma is much higher than the one that we give to our patients with follicular lymphoma. And in my experience, we cannot give the regimen every 3 or 4 weeks because of hematological toxicity. And if at the end we give the regimen every 7 or 8 weeks, the disease is not going to be very well under control. So to me, I would use rituximab and bendamustine now in combination with polatuzumab vedotin in the relapse setting. So as we have this approval now, I would not use bendamustine frontline, but in the relapse setting.
Dr. Cordoba, what about the lenalidomide maintenance therapy for geriatric patient after chemotherapy, maintenance therapy, immunotherapy, lenalidomide, low dose?
Dr. Eyre has presented a result where the addition of lenalidomide is not going to add anything relevant to the outcome. So we do not have enough data to support the use of lenalidomide as a maintenance therapy. We don't have any strategy so far to give us a maintenance. Probably now we will see the use of tafasitamab when it's approved and available in all of countries. Tafasitamab is going to be given until disease progression. So patients are going to receive a kind of maintenance therapy after the induction. So probably it will be the first time that we can give not a short time duration of treatment in this subgroup of patients. And also in the next future, we are going to have bispecific antibodies against CD20 and CD3, and some strategies also are looking for the use of these bispecific antibodies as a maintenance treatment. So probably in the future, but not so far. We do not have evidence so far to give maintenance to our patients.
Dr. Cordova, in your country, do you have any experience for patients with lymphoma, CAR T-cell treatment?
In older patients, there are some restrictions in some European countries. For example, in Italy, CAR T-cell therapy cannot be given to patients over 70. So in that country, they don't have experience. In Spain, we can give CAR T-cell therapy until the age of 75, not beyond, despite in some trials, patients up to 80 or 82 years old were enrolled in the trials. In the next EHA meeting in June 2022, probably we will have data coming from different countries, the UK, Germany, and also Spain, in order to provide more evidence about the safety of the use of CAR T-cell therapy in older patients. But the evidence so far is a bit very small.
Cordoba, if we have a frail geriatric patient, could you continue with only rituximab to prevent any progression of the disease?
If we have a very frail patient that is not candidate to receive any intravenous therapy, we discuss with the patient and many times with the family, and we sometimes offer an oral regimen such as cyclophosphamide, etoposide, and prednisone. If the patient is able to come to the hospital to receive rituximab, it's okay with this patient. But if not, if the patient has a moderate cognitive impairment, we cannot give any intravenous drug. After the discussion with the family, we offer at least something in order to control the symptoms. So cycloprednisone or cycloprednisone plus etoposide, these drugs are oral, and we can give 6 to 8 cycles at least to control the disease and to reduce the symptoms.
Thank you, Cordoba. I am going to invite next presentation presenter Dr. Mehmet Ali Özcan, who is our colleagues, and the topic is current treatment in geriatric acute leukemia patients. Mehmet Ali.
Professor İlhan, I'm very happy to be here on behalf of the founder of the Turkish Geriatric Hematology Association, our 10th year, and we are getting a joint workshop with the SIOC, International Society of Geriatric Oncology, and I would like to thank Professor Cordoba to give an opportunity to be organized together this joint workshop. My responsibility is to talk about the current management of acute leukemia and geriatric population. I'm very happy to be as a hybrid model of the virtual meeting. We are here together, Professor Gülbaş, Professor İlhan, and I'm on the site, and I would like to be together as soon as possible with face-to-face. I'm working in İzmir, 9 Eylül University. I'm dealing with all hematological diseases, and we will like to acute leukemia. In childhood, there is a difference between adult leukemia, and also we have to change the name geriatric leukemia beyond adult leukemia, as we discussed later on. When we looked at the childhood acute leukemia, ALL is the major subgroup of the leukemia. Acute lymphoblastic leukemia of the childhood is different than adult ALL as well. when we looked at the adult leukemia type, AML is the provider of the leukemia patients, and ALL is not the common type of the leukemia. When we looked at the AML in adult and AML in geriatric patients, it's also becoming increasing. Epidemiological data shows us the age of the patient become 80 and over. The incidence rate is higher and continues to increase. When we looked at the countries that are like Turkey, we look like a young countries, young population countries, but in the number of the people who be able to named as a geriatric population, we are not in the same picture. Yes, the percentage is low, but the number of the geriatric people is high. That's why we are dealing a lot of geriatric AML patients in our daily practice. When we looked at the relative survival by the age from the diagnosis to death, and you see at the lower bottom curve is the age over 75. When you looked at the curve, you can find the only 10% of the patient has a 1-year survival after the diagnosis of AML in over the age of 75. In older patients with acute myeloid leukemia, the more frequent presence of biological inherent therapy-resistant disease and increased comorbidities translate to poor overall survival and therapeutic challenges. It's not easy to continue to manage the AML in elderly, but the definition in elderly is like 60 and over patient in AML diagnosed patient. But we are learning a lot from the time period. We started to clinical implication and diagnostic and the therapeutic application in 2000, at the beginning of the 2000. But today we have a lot of new opportunity to understand and the subgroup of the AML patients and the biology of the disease. We have changed the strategy of the management because we have new targets. This target has an opportunity to establish a new treatment option, and nowadays we have new kids on the block to treat the patient in geriatric population with AML. As we remember, at the beginning of the 2000s, we have only to challenge the patient has fit to chemo or not. The decision making is just one question, but we have now molecular findings and we can select the patient beyond the diagnosis of AML. We have to think about which type of molecular differences these patients have to focus on to treat as a targeted treatment option. As you see, the AML has a heterogeneous molecular features in terms of to understand. If you have a just 15-17 translocation, which is not AML, is APL, and also we have a chance to treat the patient beyond the age without chemo with ultra plus arsenic trioxide. And if you look at the spliceosome gene molecular differences or mutations in terms of to understand the earlier myelodysplasia in terms of to understand the treatment options is not a de novo AML, as you have no diagnosis before the diagnosis of AML, but in terms of molecular picture, you can say this patient has a history what is not diagnosed earlier myelodysplasia. And if you diagnose the AML after myelodysplasia, it's not easy to continue with only chemo, or you have to think about the poor prognosis. And if the molecular findings is related with age, and is there any difference between the age and molecular findings in AML? Yes, we have. As you see in the picture, the brown column is represent over the age of 75 years old patients. TET2 mutations is higher in older people, and if you looked at the some difference between the ASXL1 is higher in also the older people. When you looked at the difference between the TP55, the age is also changed the strategy of TP55 positivity. The number of the TP55 positive patients is increasing with the age over the 75. Optimal frontline therapies for older patients with acute myeloid leukemia remain controversial. There is no standard of care to treat patients over the 60 in terms of the diagnosis of generally an AML, but we have now some challenges, and I will talk about them in new slides. If you have a patient diagnosed AML over the age 60 or over the age 70, 80, this is a geriatric population. Patient factors must be considered. Chronological age important, but the decision making is not just only with the chronological age. You have to think about the comorbidities, performance status, socioeconomic status. That is also important for your country and for your hospital as well. And access to care is important. In Turkey, in this joint workshop also, I want to try to explain the issue in Turkey to understand the SIOC in terms of how it's going on, the hematological oncology in Turkey. There is a whole cover of reimbursement by government in terms of to treat the patients in any type of hematological disease, and there's no restriction by the age. But in terms of the reimbursement strategy of novel treatment, there could be change from the EMA or FDA indications as well. And at the point, I wanted to underline the issue in Turkey as well. You have to fitness for therapy. And if we talk about the fit patient, there is no decision in terms of fitness. You have to first have an opportunity to treatment, and if this patient has an fitness of this therapy, and beyond novel treatment, we have only the treatment option of AML with combined chemotherapy, 7+3 or 3+7, etc. But in terms of chemo, age and elderly patient has a very important unfitness for combined chemotherapy. But today we have new challenges to make a targeted therapy and some kind of novel treatment option in AML, and there is a new definition which patient fit for novel treatment, which patient fit for monoclonal antibody treatment, which patient fit for hematopoietic stem cell transplantation as well. And there is a difference between the disease-specific factors. You have to think about mostly for molecular genetic findings in terms of to make a decision in treatment of AML patients who is over the age of 60. We have to decide standard intensive therapy for curative goal of the treatment for patients with AML, 7+3 plus X. Nowadays, we have to think about which patient has an targeted activity, molecular findings, or targeted chance for the treatment of patients. If the patients fit for standard intensive chemotherapy, you have to find out the FLT3, IDH1 or 2 mutations, which could be the opportunity to patients to treat with chemo plus X. And now we have gemtuzumab ozogamicin as our old friend. You remember the GO is have a bad history for the treatment of AML, but we learned a lot from the biology of AML, and we have to discuss GO is an opportunity to treatment of GBF AML in any age. In terms of therapeutic decision, we have to consider if there is any clinical trial in terms of to recruit the patient. You have to push forward for the make a good challenge the patient treatment option. And also there is medical fitness, leukemia biology, and also we have to think patient preference. But we have elderly patients, and also not only patient preference, also caregiver has an impact in terms of to make a decision making. And also we are now in SIOC coverage, and we are making joint workshop. There are very different countries to have an opportunity to reach the new therapeutic options. There will be some difference between the availability of the and also sustainability of the treatment options could be differ than one country to other country. And physician experience and attitude also is also important. If you have a clinical center to manage these patients, have no experience on novel treatment option, there could be the important effective figure to get a better result from the treatment option. In terms of the treatment option, we have high intensity standard of care chemotherapy, which means represent the second line on the graph. And you see blue graph on the solid line, hypomethylating agent. As you see, the hypomethylating agent over the time, overall survival is better than high intensity treatment. But this is a combo and combined total patient result. If you select one patient from the graph, you can say this patient fit for this and to get better result from this treatment. Survival in elderly AML by therapy is overall very dismal result, and is, as you see, overall 4.4 million overall survival. And if you have chemo, you can get a 30% 1 year survival from the chemotherapy-based treatment option. And if we want to try to make a challenge adult, 60 years and older newly diagnosed AML, you have to select goals of care and the patient-related factors. Geriatric assessment is not easy to continue with a general accepted geriatric assessment, comprehensive geriatric assessment in hematology setting, but we have now a challenge, some kind of simplified geriatric assessment for the disease, and you can use by physician, and you have to make a challenge with this type of geriatric assessment, and decision making is start with. If the patients fit the intermediate to favorable risk of disease, you can continue with 7+3 plus GO, or if the FLT3 mutated midostaurin or new kind of FLT3 inhibitors. If the patient fit but poor risk disease, you can continue with GPX351 is a kind of liposomal formulation of 7+3, and if you have a patient previous history of myelodysplasia or secondary AML, you have to continue. If the patient fit and poor prognosis, you can continue with the GPX351. And we have a challenge, and we have now a new kids on the block, venetoclax. If you have a patient fit to continue, and the goal could be the curative cure or have get a complete remission in this patient, you can start venetoclax plus hypomethylating agent or low dose RIC. If the patient unfit, vulnerable, you can select one of lower intensity treatment and also it could be the venetoclax-based combination or venetoclax-based hypomethylating agent. And if the patient with frailty, you can continue with the supportive care. It's not easy to continue supportive care with the elderly AML patients. You have to continue to transfuse these patients because of the disease specific issues. But in Turkey, we have a challenge. We have no house-based transfusion opportunity. The patient must come to any type of the hospital care and transfused, and it's not easy to continue with best supportive care as well. From biology to treatment, we have a new friends, and some of them will be the opportunity to treatment of the older patients with diagnosed as AML. And as we learned from the CLL and other hematological malignancies, the future could be the combination by biological targeted treatment options in terms of beyond conventional cytotoxic chemo. When we looked at ALL in elderly patient, ALL is the not a major leukemia in adult population, but in terms of the demographic epidemiological data, you can see with the age also some increase in terms of the ALL diagnosis in elderly patient. As you see, children and adults, there is no difference between the pediatric hematologist and adult hematologist. It is not a decision from the treated person, physician-based difference. This is the biology of the disease-based difference. As you see, the childhood ALL is different than the adult ALL. As you remember, the poor prognosis of ALL years by years, Philadelphia positivity, but in adult population, it's about 1/3 of the patients has Philadelphia positivity. When we looked at the ALL distinguishing characteristics in older patients with ALL compared with their younger counterparts, increased frailty, more pre-existent comorbidities, high rate of polypharmacy, higher likelihood of adverse events with standard dose chemo, more frequent need for dose reductions, dose delays or drugs omissions, high rate of infectious complications, and higher induction mortality than in remission rates. And also disease-related factor, as I mentioned before, this is a different disease in terms of the molecular biology of the disease. And poor outcomes in older ALL patients, and high mortality and morbidity from chemo is coming from the disease-related factors and also patient-related factors and also treatment center-related factors. And I want to try to outline, and maybe we will discuss later on, there is a new need to understand the experienced center-based treatment modalities in geriatric population as pediatricians. Not all people could treat all geriatric patients who diagnosed with hematological malignancies. And also this is a very encouraging example, time and meaning change. As we remember, the poor prognosis of the ALL in adult population is Philadelphia positivity. Now this changed as a favorable prognostic implications of Philadelphia positivity by the treatment option. TKI changed the disease-related results. Disease is not changed. Philadelphia positivity is over there, but we have an option to overcome these genetic abnormality with only oral drugs that incorporated in terms of any type of ALL treatment. And if we looked at the results from the studies that are generally not a very high number of the older people, but in terms of the decision making, we have to look out them. If you looked at the Philadelphia negative ALL studies, any of them has and just a number of patients about 50 to 100, and the overall survival at 3 years about 30% in generally, in combination with a standard of care combined chemotherapy. And if we looked at the Philadelphia positive ALL studies, it starts from the GMAMA, TKI inhibitors, plus steroids, or plus vincristine, or plus combined chemotherapy, changed everything in terms of the GAD and response rates, and also progression-free, disease-free survival, and overall survival. If you have a patient 85 years old, Philadelphia positive ALL, you can continue without any chemo with dasatinib plus steroid. You can reach the 100%, nearly 100% response rate, and the 2 years overall survival is better in terms of Philadelphia negative ALL. It's also very important change in ALL in adult, in ALL in geriatry. The Philadelphia positivity could a chance to understand GAD and response and long-term overall survival. As we discussed in lymphoma, there are new treatment options in terms of B-cell specificity targeted treatments. And now we have good results from young and also adult patients. But in terms of geriatric population, we have also new data that could the Bilina or Ino could be the option to treatment of ALL patients in elderly with in a low dose intensity chemo or high intensity chemo that patient fit for them. And in terms of the monotherapy, Bilina could get a benefit in elderly patient in terms of the remission rate, and also undetectable minimal residual percentages is higher in ALL population. If the patient have a fitness of the any type of new novel transplantation strategies, and the patient could continue with the transplantation for the cure. I will not go with detail in transplantation because the next topic will be the hematopoietic stem cell transplantation in geriatric population. Professor Gülbaş will discuss the transplantation issue. But in terms of general general recommendation, if you have a patient, you have to continue to, if your treatment goal is cure, you have to think about the transplantation in terms of to get and cure in your patients. And we have to understand, we have to learn, we have to use a lot for any of hematological oncology patients incorporate geriatric assessment in management, any hematological cancer, and also in acute lymphoblastic leukemia. I will not go into detail, but we have to learn a new strategies that is not a clinical trial based learning or clinical decision learning. It starts with you have to learn your patient, you have to clarify your patient status beyond your thinking or their recommendation. You have to focus standardized and continue with geriatric assessment. In older patients, any type of leukemia, you have to figure out you can continue, you have to pass your patient under or overtreated. You have to decision making with your patient and their caregivers. You have to optimize the treatment strategies. You have to tailor-based treatment in geriatric leukemia patients. We always remember that one day, we hope, we will be the same age as our patients. That's why we have to think to treat patient as fit the patient has an opportunity to get cure or long-term overall survival. Thank you very much.
Thank you for excellent presentation, Mehmet Ali. I want to know, what about targeted medicine in NGS area for geriatric hematology patient?
Thank you very much. This question is very important because of not NGS, but the terms of today, the opportunity to make molecular findings easily and generally in your patient. NGS is a quite acceptable and reachable strategy for molecular studies. That's why if you have a patient, you have to find out this patient have any target to a new targeted treatment option. As I mentioned, this is a kind of tailored treatment, personalized medicine strategy. In terms of cytotoxic treatment, you are sending the cytotoxic drugs all cells. And as you remember, the elderly patient has also older stem cells. It makes a challenge to side effects of any treatment also higher in elderly patients. That's why we have to focus on the disease named by morphology, but in terms of molecular biology as well.
Thank you. Dr. Cordoba, what about the SIOC policy for acute leukemia for geriatric patients?
I think there was a paper that is explained the issue of the recommendation of the patient who will treated as an elderly leukemia patients, but the novel treatment options is coming very rapidly and everything is changing currently. That's why we need to make a new challenge and recommendation paper from the SIOC as well.
Okay. What about the BiTE technology or CAR T cell new generation, immunochemotherapy or combination?
As I mentioned in my topic, the BiTEs, the first member of the BiTEs is Bilina, is a challenger, a game changer treatment option. But we have now three specific monoclonal antibodies as well, as you learned from the studies that are conducted in terms of lymphoproliferative disorders. Three specific monoclonal antibodies could change the current results of elderly patients, because if you have a patient, you have to treat patients beyond adverse events, and cytotoxic treatment is not very well tolerated treatment option in this age of patients. And the combination of small molecules that target some parts of the signal transduction, and also the combination of the monoclonal antibody. CAR T cells is validated in terms of the young adults and the childhood acute leukemia, acute B-cell leukemia, but in terms of the adult results, we are getting much better results from the studies, and nowadays we are trying to make a challenge in elderly patients. CAR T cell strategy is learning from the physicians, is learning from the hematology area. That's why we are challenging the treatment option with cellular treatment. I think CAR T is the beginner first one, and the new ones will come, and the cellular treatment is the option for elderly patients as well.
Thank you.
Dani Hocam, my question is related with the minimal residual disease following. In our country and also everywhere flow cytometry is available, do you recommend how to use flow cytometry for the treatment decision? And if the patient after the remission induction and consolidation still has MRD in all elderly patients, do you recommend for maintenance therapy for AML patients like ALL? What do you
Yes.
think about flow cytometry and maintenance treatment?
Everything is changing. You are asking a very good question. Nowadays, we have a data that incorporate and make a prediction to make a treatment challenge in BILINA studies. As you remember, undetectable minimal residual disease is also challenge for ALL patients in relapsed refractory setting after BILINA treatment. You have to make a selection. If the patient have a minimal residuals, there's an indication to use BILINA continuation. That's why the question is also already answered by BILINA study in terms of relapsed refractory ALL patients, but in AML and other hematological disorders, minimal residual disease will be the predictive factor, predictive laboratory finding, and near future we will use in daily practice. But in terms of beyond ALL, there is no predictor factor of undetectable minimal residual disease. That's why beyond clinical trial, there is no routine recommendation in all hematological malignancies. But in terms of AML and ALL, you have to focus on it.